All right, and I will go ahead and I'm going to mute myself and turn off, and I will turn it over to Kath. And I just want to say on behalf of Children with Diabetes, thanks everyone for logging on.
Cool, thank you. So hopefully you should be able to see my cover screen.
Yep.
Super, thank you. So I want to say, firstly, a huge thank you to Marissa and Children with Diabetes for supporting this webinar this evening, and also to JBRF, who have very kindly sponsored the webinar and the CPD credits. So if anybody would like to claim CPD certification for attending, please do email me and let me know, and I will happily send out the certificate. So these are my disclosures. So why are we here? Why are we talking about suicide amongst people with diabetes? Is it really a big problem? Yes, is the answer. It is a big problem. It's a huge problem. And we know that the risk of suicide amongst people with diabetes, particularly type 1 diabetes, is considerably higher than the general population. And it could account for actually up to 7% of deaths. It's highly, highly likely underreported because of poor coding on death certificates, and there are no specific ICD codes that healthcare professionals can use when they are writing death certificates. But the reality is that for every suicide, there are at least 20 attempted suicides, which is a lot of people who really need some support. And that's our job. Is we're trying with the Rescue collaborative community, with the FDA and a global initiative of collaborators to really improve identification and develop interventions that will help people. So, for example, we know that suicide attempts are likely 3 to 4 times more common amongst people with diabetes than in the general population. This is across the ages, across the genders. Transition is particularly difficult. There are time points where people are more at risk, but this is not an issue that affects only one group of society. This affects everybody across the ages. And we know that intended self-injury is also very common amongst people with diabetes. And you can see here some of the things that are classified as intended self-injury. Another thing that's really, really accessible for people with type 1 diabetes, particularly in those on type 2 diabetes using insulin, is that access to insulin. And there's a common misconception that overdose is the method of choice. Actually, whilst that's very common, also insulin omission, rage bolusing, and other mismanagements occurs, which is equally dangerous. So, and we know that those with depression are at increased risk, and we know that depression is also highly elevated amongst people with diabetes. So, what are we trying to do? The FDA RESCUE collaborative community was established 2 years ago now, and we have published a number of documents. We have held a number of symposia at various conferences, and we have a number of research projects that we are completing and initiating currently. But fundamentally, what we are trying to achieve is we are trying to reduce rates of intended self-injury and suicidal acts by people with diabetes. And to do this, we need an improved understanding of the risk factors and what strategies we need to implement in order to address them, so that we can quickly identify and provide very timely support and intervention for those who are at risk. And in order to do this, we have a wide range of stakeholders across all core areas. And if anybody is interested in becoming more involved, please do reach out to us, let us know, and we'd be very, very happy to talk to you about how you can do that. So with that, I'm going to stop, like I said, and I'm going to hand over to Rehan, who is going to talk to us about some super, super cool, funky stuff that they can do with data. So thank you very much, Rehan. Over to you.
Thank you so much, Kath. And want to thank Kath for also bringing us all together for this important initiative, and wanted to talk to you guys today about using diabetes device data to identify potential self-harm. So here are some of my disclosures, mostly related to diabetes technology. And to give you my background a little bit, I've lived with type 1 diabetes for over 30 years. I initially growing up did not want to do anything diabetes related. I was a huge nerd. I wanted to be an electrical engineer and computer scientist. So I did that. I was working in industry a little while, and then my two younger sisters ended up getting diabetes. So when that happened, I decided to change gears, move into medicine, and I couldn't decide whether I wanted to see kids or adults with diabetes. So I did this thing called MedPeds, became an adult and pediatric endocrinologist. And these days I spend about 75% of my time doing research and about 25% of the time seeing people with diabetes who are moving between the pediatric and adult world, where we lose a lot of our a lot of the people we see because there are many things that unfortunately serve as barriers for moving from one clinic to the next. So as Kath mentioned, the risks of self-inflicted injury from those with chronic health conditions is significantly higher than the general population. And the risk in diabetes is approximately doubled. We know that as we develop more and more technology, there's been more technology use, and we can argue about who has been getting the bulk of the access to this technology, because obviously it is very inequitable. And probably the people who need it the most are the ones who are given it the least. But what this does mean is that in total, we do have more technology use. And so we're generating more passively recorded data, CGM metrics, insulin administration data. And hopefully these are all things that are recorded without the need of the person living with the disease to actually upload them, because that is very annoying. But there are currently no tools to detect risky behavior using data from these diabetes technology devices. So one of our thoughts was, well, maybe if we could detect that behavior earlier, we could stand a chance at intervening a little bit earlier and hopefully get early directed interventions to those who would most benefit from them. Just to say here that obviously we've had a good number of devices approved in the US, not quite as many as in the EU, but on the open source side, we have the APS algorithms and derivatives, so Open APS, Android APS, Free APS X, and then those running the Loop algorithm, Loop and Free APS. Then we have the Medtronic current 770G, awaiting approval for the 780G, which is available in the EU. Tandem Control IQ, which was approved around the start of the pandemic. And then Omnipod 5, which was approved earlier this year. And in addition, we've just had some recent approvals of the Dexcom G7, and before that, the Libre 3. It's not an instantaneous process to get the G7 linked up with these current closed loop devices, but hopefully that will be coming soon as well. But all this is to say we have more devices than ever. Again, I think the equitable distribution of these devices is a big problem in the United States. And one of the things that we have to concede is that anytime you're looking at a population with access to endocrinologists, access to technology, they are going to be a better served population than some who do not have access to healthcare. So we have to come up into this with the understanding that while we can look at people who have devices passively uploading, it may not reflect the entire population of people living with type 1 diabetes. So the first question we ask ourselves is, okay, I have access to this multitude of data points. How do I define what is risky? frequently we'll talk about, okay, probably what's risky is giving someone more insulin when they're low or less insulin when they're high. But this doesn't paint the whole picture. I can give you an anecdote of someone I saw who had an A1C over 14%. And he had a very deliberate attempt wherein he administered something like 30 units of short-acting insulin. For better or worse, the blood sugar ended up not falling into the low range. In fact, that was just enough to get it actually into the 70 to 180 range, but that was a clear attempt. So unfortunately, that would not be encapsulated by either more insulin when low or less insulin when high. And this is a problem. So we can have self-harm intent without actually seeing the glycemic issue. But more cases also make this hard. What if someone was eating a meal after they were low, and so they ate enough that giving a bolus maybe was not a horrible idea, and the blood sugar may go up after that. The other thing I've seen is some people, to avoid leaving a paper trail or to make it harder to detect these behaviors, won't use the bolus function. They might use a prime or fill command on their pump. And so that may also make it difficult to assess, especially if you're going with standard data downloads from devices, whether that was actually, was extra insulin actually administered or not. And then, of course, that's if the pump was used at all. You could also deliver by injection or inhaled routes, and then that would not be something you would necessarily have access to information about. The other important factor is people don't wear their devices 24/7. So particularly if someone is engaging in self-harm, you might think, well, why would they want their CGM on to beep and bloop at them the whole time? So they may have removed their CGM, in which case then we wouldn't have data related to glycemia at all. Also important to keep in mind that the signal processing tricks that the CGM manufacturers use, unfortunately, may also prove problematic for the detection of these events. So I'll give you an example. One of the things that happens is sometimes there is a sudden rapid rate of change downward that could be perceived as the wire pulling out of the skin, or it could be real data. And sometimes folks will actually data blank that interval to avoid any accuracy penalties that go along with that. In addition, I don't know if anyone has tried wearing a masked sensor, but if somebody has a glucose that is continuously greater than 400, oftentimes the system will just shut down after a period or not allow you to start up if you're less than 40 or greater than 400. And so all of these things may be more common in the population with risk of self-injury. And so there you may have data gaps. And the absence of data may be possible to look at as a factor in all of this, but it's not as easy as just saying, oh, the person took more insulin when they're low, as you can tell. And then also, on the counter of that, less insulin when high, it sometimes is a question, is this more apathy or a desire for self-harm? And the motivation may not be self-harm, but the result may be very similar. Fear of hypoglycemia is actually a protective strategy for the individual. They are trying to avoid harm, but it may also mean that they run themselves persistently above target. So this too can be a little bit tough to tease out if you're just going based on insulin and CGM data. And again, removing the CGM and having those signal processing gaps when the glucose is consistently above 400 means that you might have data gaps, which would make it difficult to just use a rule-based strategy to detect possible self-harm or self-injury events. So one of the first steps we would do, and hopefully we can get funded for this project, is to take an existing data set and identify the frequency of a subset of risky behaviors. And the reason is we have to start somewhere. Despite all the limitations that I just went over, we really don't have a clear sense for how frequently we would find certain behaviors in the average population wearing diabetes devices. So finding people delivering more insulin at a glucose less than 54 with sustained subsequent hypoglycemia would seem a pretty reasonable one to look for. And then no insulin delivered at sustained glucoses above 300, maybe another one that we want to identify. And if we can at least look at the frequency, that gives us some sense of how often this might be occurring. But this would likely be an underestimate. And it completely ignores those self-injury behaviors without a clear glucose signature. And like I mentioned with my first example there, that is a possible situation. So another method we thought of to consider self-injury or self-harm events here is identifying anomalous behaviors. So there are machine learning strategies for identifying self-inconsistent behaviors. And we can make a tuple that consists of people's glucoses, their insulin deliveries, their carb intake. And so what we did was we implemented an unsupervised anomaly detection algorithm using a KNN, nearest neighbor classifier. And the model was trained on longitudinal data of a single individual to detect inconsistencies in behavior leading to hypoglycemia. And there were certainly a couple of those that are detected in yellow here, which are outside the main distribution of doses, boluses, carb amounts, and TDD that make us think, okay, these are unexpected for that individual, and so maybe worth greater investigation. And in this data set, we indeed also injected some potential self-injury events just to see if they would be detected. And indeed they were well outside the normal space of events that occur for this individual. So this may be one way of detecting potential outlier events, and we could potentially find that those carried with them excess risk of harm. And then, of course, the old strategy in machine learning is develop a classifier based on expert data. And so one strategy is you create a neural network classification strategy for individuals identified by a mental health professional as at risk and requiring intervention or not at risk. And this would just be a binary classifier. We're not sort of giving a graded risk profile here, but really what we want to know is who do we need to pluck out and place in an early intervention program. The limits of this sort of technique are that obviously the bigger your training set, the bigger your testing set, the better. And so knowing exactly how many you would need to make this optimal is challenging, but you would like as diverse a group as you could get for this sort of investigation. And it is also the case that you will require some people who will be identified as being at risk, requiring intervention. But we know in clinical diabetes research, we do a horrible job of recruiting the underserved, recruiting the at risk. So the very fact that we want to get some of that population involved is going to be difficult, because oftentimes people who are depressed don't have future-seeking behavior. They don't think, what are my dreams, hopes, aspirations, because they're just so caught up in the moment of what's going on. That group is particularly at risk, and they also seemingly would be harder to recruit for a research study, because if they don't see their own future, how are they going to want to participate in clinical research to help the population at large? So goals for this project would be to produce a tool for clinics to rapidly identify those who need help based on data that they're already getting. Obviously, the larger the data set, the better. And so once this were to roll out in the wild, you could retrain it on bigger data sets. And I would also want, although this isn't a direct result of the experiments, but I would encourage CGM manufacturers to avoid dropping signals, even if it means you might get a potential accuracy hit, particularly at times of high risk. Here's a situation, as mentioned, where glucose was falling rapidly, and what you get is a sensor error, which unfortunately the message says wait up to 3 hours, which may be too long for this person who's falling rapidly. So with that, I'll thank folks. We can either save questions to the very end, or we could take a few now if there are any.
Thank you so much, Ryan. Gosh, that's so interesting. It's so remarkable how much you can do and how much you can see that just seems like it's invisible. And yet, once you start to dig, it just seems that there's so much opportunity that you can find. If anybody has any questions, please do pop them in the chat or the Q&A. I had a couple of questions, and I don't want to hog it. So I'm just going to quickly ask one first. So you talked at the end there about people with depression and challenges with engagement in research. I wondered actually what experience or what your thoughts on the IRB view of recruiting people who are experiencing depression into research, and what are those kind of confounders of what expectations IRB would have that might confound the analyses that you're trying to conduct, if that makes sense.
Oh, absolutely. So this is the big question, and certainly one would need to have an understanding IRB who realizes that, listen, the alternative is, unfortunately, there are few diabetes clinics where behavioral health and psychology are deeply intertwined into every single visit. There are certainly cases where they are accessible, but the provider has to know to flag that person to bring them in. And so when we look at the risk rewards for this sort of experiment, one has to realize that the alternative is not, oh, this person is going to get individualized attention by a behavioral therapy expert. No, the alternative is they will be forgotten. Someone will change a carb ratio, call it done, and say that's the biggest issue you have today, which we know to be utter bullshit. So this is a situation where we really do want to get wide swaths of the population involved. We want people to understand that, listen, as part of this, we are going to get, everybody will be undergoing some form of a psychological review. They will have to be expert labeled for a clinical trial. And of course, if somebody comes to me and says this person is at risk, it will be my obligation to find them help after that, which is probably better than the standard of care right now. for a lot of clinics. So I would hope an IRB would be very supportive of this. And I would also hope that we could recruit. Again, that's my major challenge. The white college educated group has had enough experiments done on them. We need to be more inclusive in all clinical trials.
Yeah.
And particularly in this one where the outcomes depend on it.
Yeah, no, exactly. Well, you know that so we did a healthcare professional survey, you know this as part of the rescue. And that article is about to be submitted for publication. We presented at conferences earlier this year. And we have a survey for people with diabetes. And the review came back from the IRB here in the UK, I won't tell you where. And then one of the major concerns were that this is a survey for adults with diabetes. It's an anonymous survey for obvious reasons. So how will you guarantee that children won't access it and be distressed? And I'm like, you can put every health warning, you can target specifically the group, but I can't 100% guarantee that that won't happen. So yeah, I don't know what's going to happen. I do have a couple of questions actually. So Nick had asked regarding larger data sets, it seems like an opportunity for Tidepool's big data donation project and anonymized data sets to help to contribute to pattern recognition. Have you mentioned this at all to BA? So
as Tidepool's chief medical advisor, of course, yes, this was a chance to use the big data donation project to our benefit. There's a problem though. Remember how I was saying that merely having diabetes technology puts you in a privileged group. So one of the things we noticed about this data set, and remember, this was people, especially at the beginning of the donation project, this was people donating who had greater than 90% CGM data in like 2017 and 2018. Very demographically privileged group that ended up being contained in this data set. So as a result, this is not to say that there were no scary or dangerous events, because there were a couple that we actually did pluck out using our outlier detector. But I think that will be a very large underestimate versus, let's say, a pool of people maybe in the gluco data set, or who are just in the Tidepool data set and are using it as an upload tool, but not necessarily donating their data actively, because I think there is the concern too that many people donating their data, either they are okay with it or they're looking for a specific medical intervention that can potentially help. So I really do think we need to go into the clinic and not go with this sort of self-selected group. And we have to be careful, because again, you have to understand, how do the people who donate their data compare to the general population of people living with diabetes? And it's probably a subset that may be having access to more resources than you might imagine.
Yeah, no, that's a good point. So, so Nick says, thank you, that makes sense. So I have another question, and this is from a guy called Sally, who is from South Africa. And I had the privilege of meeting Sally last week at the International Diabetes Federation Congress in Lisbon. We shared a panel discussion. And Sally asked what about the diabetic with complications like amputees? And as we move forwards to submitting grant application in this area, as we've talked about as part of the initiative, somebody like Sally might actually be a really good partner to look at that. So what about people with complications such as amputees?
Absolutely. And one thing that we must realize is that certainly the population that is at risk for self-injury may or may not have in target glycemia, right? And we can each have our hypotheses about what the glycemia would look like in that population. There's probably going to be a significant spread within that population. Some people are going to be above target a significant amount of the time, perhaps for decades, by the time they're dealing with all this. And I think it's been borne out in the literature that the more medical comorbidities you have, the more likely you are to be depressed, the more likely you may engage in self-injury or self-harm. So I do think that you cannot exclude from any of these trials people who have had a hard time with diabetes and who are living with some of these complications. And the real unfortunate thing is they tend to coalesce oftentimes. So, there's the old story, if what's happening in the eyes is what's happening in the kidneys. So unfortunately, people oftentimes get this bad news in groups. And by the time, you're having significant microalbuminuria, the decay rate is really quick from that point, and you have to work quickly to make changes to sort of start to slow or reverse things. So that could be a point in one's life where they are really feeling a lot of situational stress from these events, and certainly would be a group that would need to be assessed very carefully, particularly once you're hitting a lot of complications in rapid succession.
Yeah. That's really, really helpful. Thank you so much. So I'm going to say thank you so much again, Rehan. Just fascinating, really, really interesting. I'm super, super excited as we move forward, because I think there is so much potential that it just opens up opportunities where we can develop interventions to help, and I think that's exciting. So I'm going to move on, and I'm going to say hi to Marissa and Renza. Thank you both so much. So kind of really a world apart from the kind of really technical stuff, the deep dive, to what is so crucial to so many people living with diabetes, and when done well is phenomenal, but seems to be so fraught with challenges, and I'm really excited to hear how you can do it well, and how we can overcome the challenges. So Marissa and Renza.
Well, hello. I think I'm going to let Renza start. And
sure, let's do that. Well, hi, everybody. I'm Renza Shibilia. I'm a diabetes advocate and activist from Australia usually, but I'm in New York at the moment, but Melbourne is home. I've lived with type 1 diabetes for nearly 25 years now, and I'm so excited to be talking about peer support, which is one of the things that I have spent the last 21 years where I've been working in diabetes advocacy and diabetes organizations, really promoting, working with people in the community and talking about and researching just why peer support is so important. But Marissa and I are going to have a chat, and we don't have slides, except I have one, because I think this one is a really, really powerful one. So let me see if I can share the screen and not actually stop the this whole webinar. Let's go with that. And I feel like I am almost obligated to show this slide these days, because I think it is such an important one that illustrates so perfectly what it is that people with diabetes are kind of living with every single day. So this image is, of course, the blue circle of diabetes, but you will notice that there is a tiny little white slither that has been removed from there. And what that is meant to represent is the amount of time each year that a person with diabetes actually gets to spend with their healthcare professional team. Now, I've always thought that it's between 4 and 6 hours on average, and I know that that's certainly my experience, probably more like 4 rather than 6, but we know that there are people who are even spending less time than that with their health professionals. This image was created by Manny Hernandez, an incredible advocate in the diabetes community who has been around for a very long time, an absolute shining light in our community. And I love this because pictorially we can see very clearly just how much time we as people with diabetes are doing this on our own. It's a lot of time. You know, we talk about all those decisions that we make every day, you know, diabetes being such a burden that's with us 24/7. And what sort of things can we do that can actually help us during that time? So let's stop sharing and bring us back. There we go. Because I think, Marissa, one of the things that I always talk about when I'm, I guess, highlighting the things that people can do, it is connecting with other people with diabetes. The way that I sort of make this make sense in my head is that I say that other people's diabetes help me make sense of my own. And it wasn't until I started connecting with others with diabetes that I realized that I didn't have to do this all on my own all the time. And I know that's certainly something that you and your work through CWG and all your other work and just being such an incredible voice in the community also has found. And I was wondering, perhaps we can have a chat about that.
Yeah, absolutely. So it's funny. I didn't realize I've had diabetes longer than you. So not that it's a competition. It's okay. We're all going to get there. But I've had type 1 for 31 years this year. No, 33 years. Wow. I lost 2 years just pretending they don't exist. So I think, really what it boils down to is, we as people, as humans, and I think we realize this now that we've gone through lockdown and a pandemic, how much we need social connection to really function. Even the introverts were talking about how, oh, I'm an introvert and I really miss people. And I think people who live alone had a really hard time in lockdown. And you'll hear people that'll say, yes, humans are social beings. And really, I was reflecting about this earlier today, and I think without my ability to connect with other people with diabetes, I would not be where I am today. That's for sure. And I think this is the same for all aspects in life. Like, when you become a mom, like when you go to do something different in your life, like I need to have my mom friends so that I can commiserate and tell stories and, figure out, basically realize that I'm not mucking it up as bad as I think. Like we're all kind of mucking it up. And it's the same with diabetes, right? Like we're all doing the best that we can in the circumstances that we have and, different levels of privilege that we have, right? We're lucky. Like I feel so lucky. And I know that I'm privileged because my dad started a diabetes organization called Children with Diabetes, right? So I started attending these conferences as a teenager and learned very young that even just existing as like an older child to a parent of a younger child with type 1 and just being like healthy and there and saying, hey, you're doing a great job. Like that's all that people really need is just a little bit of encouragement. And I think that's the biggest part of peer support to me. There's like the validation and then the encouragement on those days that diabetes is just, really being a pain in your butt.
Yeah. And I think one of the things that I certainly didn't realize until I, found the people who I really connected with was that for every experience that I was having where I thought that I was the only one, somebody had walked that path already. And whether it was me finding that through a blog post or through a tweet chat or in a meeting, whatever it was, like it didn't matter, whatever format it was, I would always find somebody who could share their story, but then more than that, talk about what they did through it. And sometimes, experiences would be really different and the way that we would approach it would be really different. And something that was a massive burden for somebody else would be water off a duck's back for someone else, which is fine. It's so great to get all of those perspectives. But somewhere in there, I would always walk away with some sense of I'm not alone doing this. And I feel heard and I feel that there is help. And I didn't realize that until I had just, found that peer support. And I think that sometimes that's part of the battle, I guess, is where do we find it? Like where do we find it? It's not something you get a prescription for, is it?
No, and I think, in fact, some of the struggle of this is where, and not everyone agrees and understands the importance of peer support. And sometimes, I've heard physicians say things like, oh, well, your kids will learn bad habits at diabetes camp. And I'm like, listen, like maybe they learn one little bad habit, and maybe it's like they're not cleaning their skin before they do their infusion set, which, by the way, they're going to do anyway when they're older. But at the end of the day, again, that picture, right? Like, healthcare providers are such a small sliver, and people are not meeting goals, right? And then we're also getting depressed. So having all of the tools that we can have to offer people is so important. So to me, it's, let's try and make sure that people know about the diabetes online community, that they find someone in their local community. And, this is another piece of it, is making sure that there are people that look like them and have the same experiences as them, so that they can really have that relationship.
Yeah. And I think that that's something that's really critical is, we heard from Sally before, and he was on a panel at EASD with your dad, with Jeff, talking about what people were doing when it came to peer support during the pandemic, or during lockdowns, I should say. But one of the things that I really loved that Sally was talking about was going to where people are. So I work for a diabetes organization. We love talking about hard to reach communities, and I'm so sick of hearing that, because what that means is people who don't respond to the way that we think that using the tools that we think that people should respond to. And I really love this idea of, one, providing where we can, like a smorgasbord, if you like, of everything that's available, and then saying you've got to taste everything until you find what's there for you, but also being able to support people to say, well, actually, there isn't something there for you. Let us support you however we can, so that you can create something, or then at least we can signpost to what it is that you're doing, because perhaps some of those hard to reach people, not hard to reach at all, but some of those people who haven't necessarily found that, we've got something else created that might work, because everybody is certainly going to be different. And, I talk all about finding your people and really loving them. And that's your group that you've got to go to. Everybody should be able to do that, I think.
Absolutely. And I think, when it comes to, suicide and self-harm, like we're, the focus of this, if you're, talk about hard to reach, it can be really difficult for people to ask for help when they're feeling so hopeless and so down, and it can be really hard. And that's something where I think peer support fits so perfectly, because those are the people that you are most comfortable talking to, right? And raising this conversation in the diabetes community is also going to help people know that, again, they're not in this alone, right? Like, many people have talked about their experiences having suicidal thoughts, what they did to get through it. And, I think these are important conversations. And what we did at Children with Diabetes Friends for Life this last summer was we had a session about it. And it was our first time, even having this as a topic. And, people were kind of like, oh, I'm not sure how this is going to go. And I was like, we're going to do it. and so we did. And it was standing room only. People stayed for an hour longer to keep talking about it. And we're going to do it every year. And if nothing else, right? Like, we're not going to save everybody. We're not going to fix everything, right? But if we can just help people have conversations with their loved one that has diabetes and make sure they know that they're supported, nothing bad can come from that, right?
Absolutely. And I think that that's one of the things, is that this is probably not a conversation that people are having with their healthcare professionals. And I think part of that is because it is a big issue. It's a scary issue. It's a taboo issue. There's stigma, all of those sorts of things. And often those sorts of discussions start in the community. And, I know that one of the projects that I did a number of years ago was writing a resource about insulin emission and restriction. And I remember we did some research on this, and I presented it at a conference, and I had that exact response from somebody. A dietitian stood up and said, well, this is great. Well done, you've just written a how-to manual for how, for people to now know how to do this. And I'm like, we did research that showed over 80%. And in this group that we had researched, it was women aged 18 to 45 had at some point restricted insulin for the purpose of weight loss. Are you telling me that people don't already know this? If we're not talking about it, it goes underground, because the other thing that we heard time and time again from the women that we spoke to was, I thought I was the only one doing this, and because no one's spoken to me about it before, or no one, So when we have these discussions, suddenly there is that support and avenues where people know that there is help out there, that there are research projects like this happening that people can tune into and learn about and connect with. But I always wonder how we do better at having the conversations that are hard, because they are hard. Like, there is nothing easy about having this conversation with anyone, but how do we do it so that we do normalize it as much as possible?
Yeah,
you don't have to have solutions, Marissa. I'm not.
I know. I'm like, I don't have all the answers, but I think even us just doing this today, and I think, going back into our communities, like Saleh and his group, maybe it's just asking the question, like, has anyone ever thought about this? Have you felt that, you wanted to harm yourself, or, just having conversations about it? It's interesting because, one of my friends that, does not have diabetes had some recent suicidal ideation, and, called the suicide helpline, which is really great. It's 988 now in the US, I believe. Well, I'll double check that in the Q&A session. But, he called and he made a plan and all of this stuff. And, he called me, and I had shared with him, like, listen, I also had suicidal ideation when I was younger, even as recently as a few years ago. I had switched medications, and it was not the right fit for my brain. And, it was hard, but at the end of the day, I got through it. I called my mom and had her come stay with us for a few days when I was, really struggling. I had called the hotline, and just having these conversations, like, you'll be surprised how many more people have had these experiences, and being able to connect and feel more comfortable. I think that's what we have to keep doing. And, about the insulin omission and those kind of things, I know that there are some groups online that are like peer support for people with disordered eating, with diabetes, with insulin omission and things like that. And I think it's been really, really helpful. And I hope maybe that's what can come out of, this project, something similar.
Yeah.
Enter Kath.
Yeah.
Hello. If I jump in, because so true. When you think, for example, like the World Health Organization data says that for every completed suicide, there are approximately 20 suicide attempts. That just shows you the scale of what's occurring, and it is all of the evidence clearly shows that speaking to somebody, raising the issue of have you considered, how are you feeling, does not increase their risk of committing suicide, of taking their own life. In fact, it provides an opportunity for them to get help. I have some questions in the Q&A. So Sally, I just lost a family member aged 36 who asked for my help as he was diagnosed with type 1 before I went to Lisbon, and felt so bad when I came back that I could not be there for him. How do we cope with this in the peer support? And actually that's kind of a question I kind of thought myself is how do we best support peers who are supporting with what can be some very challenging conversations and experiences? How do we help them around feelings of guilt and not doing enough, for example, even though obviously we're doing enough?
Yeah, and this, we talked about this a little bit before we got on here, and the example that I try to use, even as I tell myself, I'm like, Marissa, remember this, is that, you have to put the oxygen mask on yourself before you put it on someone else, right? And, if this were easy, if this were something that, we knew how to handle, we would be doing it, right? Like the fact is, and we just had, recently there was the famous DJ Twitch, I believe. Yeah, who was Ellen DeGeneres' DJ, I guess. I don't know much about the gentleman, but he was 40 and he just committed suicide. And I've seen a lot going around about, oh, well, he had everything. And if he still did this, right? Like obviously we don't know the answer. And remembering that it's not on you, right? It's really like there's no way that that's going to be a contributing factor in a negative way, and so but I think you will need to talk to someone in your life who can help you through these feelings, whether or not that's a friend that knows how to help navigate this, whether that's a psychologist, a counselor, a social worker. I think we should all be in therapy. I don't know about you, but like we all have stuff to work on, right? And so, I would really recommend if you're in a scenario where you're feeling hopeless, helpless, and overburdened, finding help for yourself to work through it. And as I've learned, and I'm not a psychologist, right? I'm a diabetes educator and a nurse, but you can't just put that shove it back in the back of your head. Like it doesn't.
It's not going in a box. Yeah.
But I think, I see that there are some comments.
Do you want to pick those up, Brenda, actually from Lindsay?
Well, yeah. So firstly, yes, I absolutely think that the language point is really important as well. But I do also want to, this is such a big issue, right? So expecting everybody in the community to suddenly be a really great counselor and be able to deal with somebody who is having a really tough time and is saying, I need help. I'm not a counselor either. I live with diabetes. That's my gig. I can talk about my own experiences, but that's where I start and end. But I think that, so there are a couple of things here. I think that we need the more conversations that we have about this and the more places that people know where you can turn. I think that is important, because I certainly can't help somebody in any other way other than to say, can I help you, direct you to somebody who can help? I am not a counselor. I am not somebody who can provide anything other than I can walk with you until I can find you somebody who can help. Now, not everybody's even going to have the ability or the bandwidth to do that right now, and that's okay as well. But I think that at least being able to point people to the community to say, see if you can reach out here and somebody can help you. Please just use this as a starting point. And the number that you mentioned earlier, Marissa, in Australia we have Lifeline, we have Headspace for young people, and we have Beyond Blue. Even having those sorts of resources available and just saying, can I help you, dial that number. Here's where to go. And also just to highlight that, again, this is not you alone. And I think that is something that people need to hear. And I know that, I've had some really tough times with diabetes, and the things that made the biggest difference to me was not somebody swooping in to fix it. It was somebody sitting with me or just being with me. And I don't think that's the answer to everything, and that's absolutely not going to make it better for everyone else. But having that ability to just sit and wait, I think is really incredibly useful sometimes. And when I speak to people who feel that real isolation, it's because they didn't know where to turn to find that person.
Yeah, and the stigma is so prevalent. But I am going to pick up on this point actually about major depressive disorder, and I will go back to some of the other points in a second. But I think this is crucially important, and I thank you for raising this. Is that major depressive disorder is a medical condition, and medical attention is required. So we should always seek help from a healthcare professional for issues around depression and major depressive disorder. It does go with social support, but you are absolutely right. It is a medical condition, and clinical care is necessary for that. So thank you for raising that. So Valentina says, what can healthcare professionals do to encourage people with diabetes to seek peer support in a compassionate way? And should this be done immediately after diagnosis? And I'm just going to say that peer support comes in so many different ways, and not people, especially now, places like Twitter can be a really scary place.
Yeah.
And people can be blunt in their response. And what is in their head is not what comes out to the other person, So this compassion around how do we compassionately help our patients navigate peer support and benefit from it, and what is the time for that? Is it a diagnosis when people are kind of like hit with a tidal wave, or is there an optimal time?
I think that when I was 24 when I was diagnosed, and if somebody at that point in time had have said, I'm going to introduce you to a group of people with diabetes, I would have run in the other direction screaming, because I didn't know what diabetes, there was no diabetes in my family. I had no idea. And in my brain, I had the idea that peer support was sitting around in a circle singing Kumbaya. I wasn't going to do that with anyone. I was not interested in that. But what I wish was that I had been told that you might find connecting with others useful at some point in time. Mm-hmm. And if you want to investigate that idea, here are some places you might go to find it. Because I found it online when I realized, actually, I've got an amazing support network. I'm so fortunate and incredibly privileged to have an amazing family and great friends, but no one understood the lousy diabetes stuff I was dealing with. So I went online and I found this incredible Australian online community called Reality Check, young adults with diabetes. And that was really great, but I wish I'd kind of been told, because I sort of had to do, I found all the cinnamon pushes before I found the community that I needed, right?
Cinnamon not working for you,
The cinnamon didn't work, and I tried, but I didn't. But I think that, I don't think that it should ever be forced on anyone, but I feel what I really wish was that there is hey, at some point, you might like to connect with other people.
Yeah.
I also wish that at the point of diagnosis, somebody had told me that seeing a psychologist, whether then or later on, would have also been a good thing. I think that's equally as important at diagnosis. And also that peer support can come in a million different ways, and you've got to find the way, and no one else can do that for you. You've got to find the way that works for you. And that might be an online group where you can be very anonymous and just lurk and learn. It might be something where you're more active. It might be going for a walk with a friend with diabetes, a weekly support group, whatever it is. And if the first thing that you come across doesn't work, don't discount it forever. Keep going back in there until you can find and connect with a group that you want to.
So I'm thinking, if you go to the rescuediabetes.com website, rescuediabetes.com, that's the collaborative community website. It's a resource for information, and there are a number of thank you, Marissa. There are a number of helplines and numbers there and websites for professional support. But I wonder, Renzo, maybe what would be helpful for healthcare professionals is if we compile, as in the royal we, as in you and Marissa, and Nick and the peer support guys on the group, a list of resources that healthcare professionals could just signpost rescuediabetes.com, and people can go and see, here are kind of peer support resources, here are professional resources. You might want to take a look or not, but there's a resource.
Yes, I think that is really useful. But I will say that in between us getting that done and now, local diabetes organisations are often a really good starting point, to see. And also, it's looking for community groups as well is really useful, and often they come from local diabetes support groups. But Children with Diabetes is an absolutely brilliant resource. The DDoC community out of Europe and globally as well is a brilliant resource. There are some absolutely easy to find, but then easy to make connection groups out there too. And I just do want to pick up on that point that one of the peer support community is an incredible resource at self-regulation as well. So, I made that comment about cinnamon before, but really, you know, if anyone got into a group and said stop taking your insulin, take cinnamon, they would be shut down very quickly. But in exactly the same way that when we're talking about, you know, big scary issues like this, the community is the first thing they say is, how can we help connect you to a healthcare professional? Because that is not what we know what we can provide, but that's not, you know, that's not what you need by and large. Let us help you find a health professional who can really help you right now, because it is a medical crisis.
Yeah, no, absolutely. And on that note, we have come to time. So I would like to say just such a huge thank you to each of you for being part of this webinar this evening. It's just been brilliant. I've really learned a lot. We will get some resources, some links up onto rescuediabetes.com. We'll do that as soon as we possibly can. And I just want to say thank you very much, everyone, for joining. And I hope you found it useful and interesting. Thank you so much, guys. I appreciate it.
Thank you.
Thank you.